Oh.
How's that?
Yeah, that's not nice.
It's not bad.
Oh.
Sensitive?
Yeah.
Okay, so for me, I'm gonna push down, resist. Okay, still a little weak.
Yeah, right there.
Yeah, okay.
That's where it feels like my bone is bruised.
Push through the foot. Don't move through your hip. Push through the foot and come out.
Yeah. Yeah. I guess I needed a lot of shock.
Sensitive here?
Yeah.
Any sensitivity? No. Look at that. No impingement at all. What's up, everybody? Dr. Ranen here. Today I'm with another special guest. I'm with Caroline Leon. Caroline is a good friend of mine. We've been working together for the last 2 years, and she recently has broken a Guinness World Record. She is the first female to summit the 7 highest volcanoes in the world in the fastest time. Okay, and she's in the process or attempting to break a second Guinness World Record, which would be to summit to summit 7 highest peaks as well.
The 7 summits and the volcanic
There we
summits.
go. Okay.
Yeah.
All right. So there's a lot of peaks and there's a lot of summits here. Okay. So Caroline came back from an expedition, yes, about 2 weeks ago. And upon her return to Dubai, she started to experience some left-sided knee pain and impingement in deep knee flexion. So she came to see me probably the next day after landing. We assessed her knee. We found some positive meniscus tests. Subsequent to that, she's undergone an ultrasound and an MRI. So the MRI has found a horizontal tear of the lateral meniscus in its anterior portion and a horizontal tear of the medial meniscus in its posterior portion or posterior horn. Okay. After our session, we saw quite a bit of improvement in strength and a reduction in pain. Yes.
And increased mobility.
Increased mobility. Okay, so what we did in the first session was we worked all the muscles of the hip, which helped to stabilize the knee, and we worked the foot and ankle. So Caroline has a very, I don't know if exciting...
Torrent
history, there we go, yeah. She had a climbing accident, and basically she's just being held together by tape.
Screws, yes.
Yeah, screws at the moment. So working the foot and ankle was a big part of the treatment process because she's got a bilateral calcaneal history of bilateral calcaneal fracture. Yes. Okay, so it does make the foot and ankle unstable, and that's obviously going to load the knee.
Yeah. Interestingly, there was a test. No, what? So the other day, what is this thing again called? It's like hypermobile here.
Yes. So he did
both sides.
Yeah. Yes. So he did mention, Dr. Gus did mention to me on the ultrasound, he found that your tibiofibular joint, or I think he said tibiofibular joint was unstable. Yeah. I just need to check his message again.
Move the whole thing. And he was saying to me that that should be rock solid.
Yes. Okay.
It's not rock solid.
No, it isn't. It isn't. All right. So Caroline is heading off to attempt to summit Everest in 6 weeks. So tomorrow she's going to head over to our good friend Dr. Gus to get a cortisone injection into the knee. But we are going to continue our assessment and treatment protocol with her. So we're going to reassess the knee. We're going to check out her muscle strength. We're going to do some shockwave in the knee joint to help with the effusion and the meniscus injury. And hopefully we can continue to establish some progress in that knee. Thus far, Caroline has mentioned that she feels 70% better. So we want to get to 100 at least in the next week to 2 weeks. All right? Shall we get you on your back? Let's go ahead and assess you. Okay, let's have a look.
So that already...
Sensitive.
Yeah.
Now, which side of the knee? Internal?
It's here.
Outside?
Yeah.
Lateral. Okay.
Still the same place.
Okay, so that's a heel to buttock test. It's about... The more I go, the more... Does it get sensitive?
Now it's just moving here.
Okay, so we got, let's say, half a centimeter. Not bad.
You mean
Okay.
from my bum?
Yes.
Yeah.
It's not bad.
Ah,
Sensitive.
yeah.
Okay, so
Still,
this is a McMurray test, yeah?
it's not pain. It's just like, no, it's kind of pain.
Anything on the
just-
inside? No.
Just there. Oh,
Okay.
but then it's again on the outside.
On the outside, okay. Let's test. Any sensitivity?
Only where this hand is, but it's like it feels
When I
like
do this?
no, the other way.
Okay, when I do that?
Yeah,
Okay,
but it feels like the bone there is bruised.
okay. Any sensitivity?
Yep, same thing. Just
Any sensitivity? No. Okay. All right. Let's test out your foot. Go out for me, please. Hold.
push.
Yes. Yes. Go. 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 That's much better. In for me. Hold. Yes. Oh no, that needs some work. Ooh. That needs some work. We gotta be careful.
I might just fall apart.
Yeah. Lift your foot up for me, please. Up, up. Hold, 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 hold. Okay, great. Push your foot down for me. 1 second, 1 second. Push down. Push, push, push. Okay, that's much better. Okay, let's check your soleus. Push for me.
See, that feels a bit funny in the back of my knee.
In the back of your knee. Okay. All right. Lift your leg up for me. Hold. I'm going to push down, resist. Much better, but it starts to fade a little, yes?
Yeah.
Turn your foot out for me. Let's check the psoas. Go. Much better. That's good. Let's get you onto your side for me, please.
This way?
Yes, please. Straighten your leg for me. Hold. All right. I'm going to push down,
Yeah.
resist. Oh, still a little weak, eh?
Yeah.
Hold for me. I'm going to push down, resist. Okay. Still a little weak. Let's get you face down for me, please. It's left side, yes?
Yep.
This is the left side. Okay, I'm going to push down, resist for me. Keep your knee in contact with the bed. Resist. That's not too bad. Let's get you to lift your hip up for me. Hold. I'm going to push down, resist. Not bad at all. Okay. Let's get you on your back for me, please.
Better?
Sorry?
Do you think it's better? Feels
Yeah.
better.
Your some of the muscles in your hip, your psoas, your glute max, much stronger. Your hamstring much stronger. Your quad is better, but it starts to fade a little bit. So we'll obviously do a stim of your quad, and we'll do some rehab for you. I'll just show you how to load the quad in maybe a better way. Okay. Any sensitivity here?
No, it's just on the outside.
Any sensitivity here?
It's a little bit further up.
Ooh.
I think that's just hard. You're pressing hard. It's
1 second.
like here.
This is the joint. Yeah, this is the joint. 1 second. Let's get your leg into this position. Here.
So it's close. There's like, it's very, yeah. So as you went down, yeah, right there.
Yeah. Okay.
That's where it feels like my bone is bruised.
Any sensitivity in here? Any sensitivity in here?
No.
Yeah, Dr. Gus mentioned you have some Hoffa fat pad impingement as well. Now
What-
that I...
What is that?
So the Hoffa fat pad sits just behind the patella tendon. It's basically a piece of fatty tissue that helps to cushion the patella when it moves inferiorly. And when you have major inflammation in the knee joint, the Hoffa fat pad becomes irritated. It's highly vascularized. So when there's inflammation in the knee joint, you're going to have increased blood flow. That increased blood flow into the Hoffa fat pad and into the joint causes it to flare up and swell up, which causes some impingement. Let's get going. We'll start with a stim of your quad. And we'll do your lower limb, and then we'll get you to turn to your side, work your glutes, and we'll head downstairs and do some shockwave. But before we do that, you wanted to show me a few areas or a few movements that were sensitive to you before we started.
Yeah.
Yes.
So,
you want to show me?
like when I'm exercising, after a while I start to feel like there's something in the back of my knee. Like I think I mentioned this to you.
Yes.
But like, so for example, if I do this doesn't feel so comfortable.
Okay.
Like, whereas before it could move freely and I can just feel this on the side. And then the same thing, like this is awful.
Yes.
Like, there I can't go any further.
Okay,
so I'm stuck.
This is the meniscus. Okay.
Yeah.
Internal rotation of your kind of leg
Yeah.
is going to load the medial meniscus, and that external rotation position is going to load the lateral meniscus,
Which is where they're both torn.
Yes.
Great.
There
Okay.
we go.
That's where yeah, it's really strange. So this
Yeah, that's
Yeah.
really tensioning that joint, and that the joint is unstable.
in this position.
In this position. Well,
Okay.
your joint is unstable, inherently unstable,
Yeah.
right? So putting pressure across it is just kind of opening it up,
Yeah.
and it's also loading that meniscus.
Okay.
Okay,
I see.
probably
'Cause I've
pushing
been,
against your
like-
lateral collateral ligament as well.
Yeah, I've been like helping it like I'm 80.
Yes.
It's awful.
Now,
and
this
then-
should get better
Yeah.
as the inflammation subsides in the knee, but it may not be 100%. Okay,
Okay.
all right.
And then just getting up off the floor. Like if I sit on the floor, I normally can like do this and push.
Yes.
I can't do that on this side.
Okay.
I'm like,
Yeah, for the moment, because you can't get into deep knee flexion as well,
Yeah.
right? Okay. So, but these are not essential movements for you, or
no, but in mountaineering, I have to say, like if I put crampons on and I'm walking up ice,
Okay.
I sometimes have to kick in the ice this
I
way.
got it,
or
got it,
like,
got it.
Like turn
so
my
you need
knee,
this mobility.
kind of. Yeah.
Okay, all right. So let's shoot for improvement in these positions for you, I think.
Okay.
Right? It's unusual, but in your case, I guess we need it. All right, let's lift this quad this up a little bit. Okay, so how's your thesis going?
Oh, it's very bad.
Very bad. So Caroline is multi-talented. She's also a hypnotherapist. So technically you are a psychotherapist, yes?
Yes.
Yes.
And a transpersonal psychologist, but
Transpersonal psychologist. So you are, can you remind me the title of your thesis at the moment?
oh, at the moment I'm doing it. So it's like the transpersonal effects of like near-death experiences.
Okay.
So I was looking into, do you know Dr. Pim van Nommel? He's a cardiologist
I don't.
who had a lot of patients who were having cardiac arrests.
Okay.
And then he was doing like these huge interviews with them to see what their experiences were.
Wow.
It's basically rooted around like the transpersonal effects of near-death experiences, what happens to people, how they experience it,
Now-
how they come back.
I thought you were doing some work around DMT.
Oh, I was, yeah.
Okay. And
Yeah.
that didn't, that didn't get passed, or
No, I just because there's a lot of regulation
Yeah.
in terms of being able to interview people who have had experiences like that. So I
Yeah.
just moved away from
Okay.
from those.
Well, with Robert Kennedy Jr. coming in, you don't know.
Yeah, that's
You
true.
you may have some opportunity to revisit.
Yeah, things might change.
Things might change. All right.
So do you think it's like, do you think that sumo deadlifting is like, do you think I'm not gonna hurt myself even more by doing that, right?
You need to use pain as your indicator of what you can and cannot do. And if you're not triggering any pain or discomfort during the sumo deadlift, you shouldn't have an issue. It's
Okay.
kind of a hinge
That's-
movement,
ooh.
just with some knee flexion.
Yeah, that's good advice actually. I can understand that really
Yeah.
well. Yeah.
Just use pain as an indicator, because
Yeah, because so when I
Your-
have pain, I pull out and stop.
yes,
And when there's no pain, it's okay.
There
yeah,
you go.
got that. That's easy.
because your circumstances are different. We're working on a timeline, and you're not like the mechanics are not standard like a football player or a rugby player.
Yeah.
You know, we kind of know what to expect with them. Mountaineering is, things can change, terrain's going to change, position can change, you can slip, you can fall. You're sleeping in tents.
Yeah.
You're not exactly sleeping on a bed, right? So you're going to put your knee into compromising positions.
So this like wakes up the muscles, right?
Basically, yeah. It
Ooh.
it more wakes up the connection between the brain and the muscle. So actually, the concept of arthrogenic muscle inhibition the term arthrogenic muscle inhibition was first coined during research of knee injuries and the effects on the musculature around the knee subsequent to a knee injury. And what the researchers found was, after a knee injury, your muscles around the knee switch off. Okay?
Oh,
It's a
okay.
guarding reflex to
Yeah.
prevent you from injuring yourself further.
Yeah.
That concept of arthrogenic muscle inhibition, I personally think it applies all around the body. All joints are the same. They need to be stable during movement, right?
Yeah.
So an injury to the joint is going to affect the body's ability, not the body's ability, I mean, it's going to go into a guarding reflex, right? Inhibit the muscles and try to prevent you from injuring yourself further. So the idea is to kind of trick the brain into thinking that there's no injury by passing the impulse through the muscle and kind of overriding the sensitization mechanism that's going on.
Yeah.
Right?
So basically you're telling the brain to turn on the muscles again.
Yes.
Okay.
We did I think last week we did a nice experiment with a bodybuilder that just tore his bicep. It was 9 weeks post-op,
Yeah.
and we tested his bicep muscle strength. using a dynamometer, which is basically a muscle testing device. We did the electrostimulation and then we retested him. And there was a 56% improvement in bicep muscle strength post intramuscular electrostimulation, which is
That's
insane.
huge.
Yeah. Honestly, I didn't expect that type of response. And all that's doing is just improving motor control pathways.
Yeah.
Cool. So when you're walking, you're still doing the Stairmaster?
Right now I haven't been, but I'm gonna start next week.
Okay.
I just thought I'd give myself one more week of.
You walking on the treadmill?
No, I'm walking outside in the park.
Okay. I think wearing a knee protection will be great.
Sure, I can do that. I have one.
Yeah. Just something like a neoprene sleeve.
Yep, I have a
Because
sleeve.
you want to make the joint feel stable. And what this will do is it will help twofold. It will help to prevent arthrogenic muscle inhibition because the body is not going to feel like it's unstable.
Yeah.
And it needs to switch off. And by preventing arthrogenic muscle inhibition, it's also going to help ensure that you don't get pain.
Yeah.
Oops. We didn't get the response we wanted here, so I'm just going to move the placement of the needle. Ooh.
Oh, just then I felt that. Is that what's meant
Good?
to happen?
That's
yeah.
what's meant to happen.
Yeah. I guess I needed a lot of shock.
Okay. So, as I'm treating you, I'm remembering stuff that Dr. Gus told me. He also mentioned that he suspects you have some peroneal nerve neuropathy. Okay.
I had that nerve blocked when I had my feet done.
I see.
When he was saying that to me, I was like, oh, I have a scar from this. So do I have needles? Can you see it? It's like a dot.
Oh, yeah.
Yeah.
Okay. Just be careful.
Yeah,
Okay.
when I remembered he was saying something to me and I was like, oh, I'm pretty sure I remember someone burrowing around my nerve trying to block it. Whether they did something more than block, I don't know, can that damage it, having a nerve block?
If it's not done under guidance and they...
It was an anesthesiologist.
Yeah, I know. But
supposedly he knows what he's doing.
yes, hopefully. Well, you would have known that something would have gone wrong if you got a foot drop. That's what happens when the peroneal nerve is affected. You get a foot drop.
Yeah, I don't have a foot drop, but
No.
on that side, I don't feel half my foot.
Yeah, but this can also be
Other
nerve
things.
damage. Yes.
Yeah. So what does that peroneal nerve look
Do.
like? Yeah. No, what's the pathology of it? What happens? Why does he suspect that?
I think maybe he saw a thickening of the peroneal nerve on ultrasound. And when you have a thickening of the peroneal, when you have a thickening of any nerve, it generally indicates that there's a neuropathy that's happening around the nerve. And what that can contribute to is pain or any type of neural sensitivity, numbness, tingling, motor deficit
Okay.
in the lower limb. Now, we assessed your lower limb at your last session, and you didn't really have any of those. Besides, for a little bit of muscle inhibition,
Yeah.
nothing that was more significant than a 4 or 5 on a muscle rating scale. Okay. So I don't think it's too much of an issue. It may be contributing to some of your pain around the knee. What we will do is, I don't know if I'm going to get into the joint through the medial and lateral meniscus. What I may do is use the shockwave through the front of the knee to help more the joint effusion. But I'm definitely going to use the shockwave to reduce the sensitivity of the infrapatellar branch of the saphenous nerve, which gives you pain around the inside of the knee.
Yes.
Don't worry, you'll know what I'm talking about when
I
when
got
we
the
get on
patella
there.
part, and then
Yeah.
after that, I was like, what?
And then your lateral femoral cutaneous nerve gives sensitivity to the outside of your thigh. So we will try and desensitize that branch, and hopefully it will help to, by reducing the nerve sensitivity, hopefully we can improve some of your range of motion, meaning the deep knee flexion, right?
Do meniscus tears heal?
The ones you have,
Yes.
those don't heal, dude.
Why?
It's quite large, right?
Oh.
Um,
So I have to come back and get surgery on it, right?
Now, okay, let's talk about heal. What does heal mean? I think there's two parts of it. The first part is the tear itself going to close? Okay. It's unlikely that a tear that large is going to heal by itself. But the other component to heal is, could you function without any pain or discomfort?
Yeah, that. Okay.
That's probably more likely.
Yeah.
Okay. So, I mean, lots of people walk around with meniscus injuries and it doesn't affect them. I have bilateral radial tears of my medial meniscus, and it doesn't affect me.
Oh, okay.
Okay. So a radial tear is slightly different though.
Okay.
Okay. A horizontal tear is a little bit more aggressive.
Yeah, so
Okay.
basically it's that way.
Yes. Okay. So yeah, I don't have any knee issues. I mean, this morning I did hack squats, 160, 180 kilos, no issue. Okay, I can get quite deep. I don't have any pain or discomfort. Okay.
Okay.
So that's just making sure that my quads are really strong. My glutes are really strong as well.
Yeah. Do you have other patients that have meniscus tears and they live normal?
So I've had a few here, people with advanced meniscus injuries. The problem in Dubai is everyone wants to fix their injury and play sport. You know, there's no rest. There's no, okay, I have this injury, I'm going to take a break. I'm going to do the recovery and I'm going to come back. So what is happening is we're seeing more guys that are opting to go and do surgical procedures so that they can get back into training faster.
Yeah.
Less people are prepared to go through the whole process of deload, rehab, progressive reload, and return to sport. So in a nutshell, I'm not seeing as many as I would probably see back home in South Africa, or even during my orthopedic specialization in Mauritius,
Yeah. Okay.
where people were really opposed to surgical intervention,
Yeah.
even infiltration procedures.
Okay.
That being said, if you look at the research now around knee injuries, especially like ACL, most of the research coming out is saying, you can rehab a patient back to return to sport, and they can have really no issues.
Okay.
Surgery is not essential. I guess, look, I'm not an orthopedic and I don't specialize in ACL injuries, but there's obviously certain parameters which you want to look out for and use that to make a call whether or not you are going to operate on a patient. I think if you're getting paid to play a sport and you want longevity in that sport, you're probably going to opt. But if you are just an office worker,
yeah, there's no need.
There's no need, really.
I understand.
All right. Let's get your foot in for me. Turn your foot in. This was kind of weak before. Let's go. Push. Yeah, that's what we want.
Yeah,
much better.
Feels like it's on.
Yeah. Okay, 1 second. Okay, straighten your leg for me. Hold. I'm going to push down, resist. Resist. That's what we want.
Yeah.
Okay.
Feels much stronger.
Feel much stronger, right?
Yeah.
Okay, let's get you to turn to your side. Out of interest, I just want to test the glutes and see if it's better. All right. Let's get you to bend your bottom knee, straighten your top knee, hold for me. I'm going to push down, resist, resist. Much better. Come back.
Yep.
Hold for me. I'm going to push down, resist, 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 resist. Great. Fantastic. So, on your back, that just shows, on your back, this back, there we go. That just shows if you improve stability in one joint, it can affect the brain's kind of process of arthrogenic muscle inhibition, okay?
This is what a TENS machine does too, right?
Yes.
No? But that's broad. It's not
broad.
specific.
It's, okay, in that sense, yeah, I understand what you mean. I am specific because I'm using the acupuncture needle to target specific nerves and specific muscles.
Yeah.
Yes. It's also a little bit more for stronger stimulation because we're bypassing the surface of the skin. What I found with TENS is, and a friend of mine had done a research study looking at the effectiveness of TENS on lower back pain at 10, 15, and 20-minute intervals, and there was no difference. Okay?
Yeah.
And I think this is because some of the stimulation is lost because it needs to pass through the skin, through the muscle, to the peripheral nerve, from the peripheral nerve to the spinal cord.
Yeah, I see what you're saying.
When we do the deep stimulation, we cut out the skin, we cut out the muscle, we go straight to the peripheral nerve.
Yeah.
I just want to test what your range of motion is like. Can you relax your leg for me?
Yeah. Can I can go all the way.
Wait, let me do it.
Sorry. Okay, now it feels uncomfortable, but I can go further.
Any change from before?
It's just like here where your hand is.
Okay, well, you got heel to buttock now. Okay. All right, let's head downstairs and do some shockwave.
Okay.
Okay, guys, so we're down in the modality room. We're going to be using some shockwave therapy. Shockwave therapy is fantastic for joint effusion or inflammation in a joint caused by meniscus injuries and or osteoarthritis. So we're going to give it a shot, even though Caroline is due for her injection tomorrow. We're going to give it a shot and see if we can have an effect. If it does have an effect, once 7 to 10 days has passed post corticosteroid, we'll pick up with the shockwave and hopefully we can eradicate any discomfort in the knee. All right, you ready to go?
I'm ready.
Okay.
Are you
Keep
gonna
your foot there. I'm just going to sit in this position, okay? Okay.
Has the discomfort started?
No.
Okay.
Has the discomfort started? You'll feel it now.
Okay, I'm just checking. Oh.
How's that?
Yeah, that's not nice.
One second. This thing is... You don't want me to increase the pressure, do you? What do you score it on a scale of 0 to 10?
Honestly, it's like a 4.
Okay.
But there's like certain positions that don't feel nice. Like, that's actually okay. There's one that goes down That feels awful.
Okay.
Way nicer on the patella than on the side.
How's that?
That's better.
Still okay?
Yeah, this side it's like 1 maybe.
Okay.
Oh,
Since it was 1 out of 10,
that was mean.
you just had a few seconds left.
I know.
Okay.
How is this end different?
So the 3 centimeter diameter head is more for neural desensitization.
Okay.
Although they say that shockwave penetrates, penetrates a certain depth, the change in head changes the focus of the acoustic waves and how it penetrates the skin.
Okay.
And how it penetrates the joint rather. Okay, I'm reducing this all the way down, but I have to, it should start at 2.5 bars. I'm starting at 1.5.
Okay. Oh, there's so much warning about, is this really bad? Have you had this before?
You're gonna feel it like it's in the bone.
Okay, great.
He's
Damn.
just kidding.
How's that?
Okay.
Remember I said intrapatellar branch?
Yeah.
There you go. Now you know what. Now you know what it's about. Sensitive here?
Yeah.
Where's it most sensitive?
Kind of like on the side. Oh, no, on the top. On the top.
How's that?
That's okay. There's like some sections that are like, oh. But then it's... I can do this.
Where's it sensitive? Down here?
No, now it's okay. It's more like right, yeah, there.
Did that feel like it was in your bone?
Yeah, parts of it.
Yeah.
Parts were okay, but then there's like, so right here, and then right here,
Yeah.
and then there's like a part there that was.
And that's just the surface of the skin, dude. It's not that deep. It's just hitting the surface of the skin. See?
So we have to do more?
No, we're done. We do
Okay.
3,000 shocks and that's it. So what we'll do now is we'll just go and do some Peterson step-ups to activate the quad and we'll be done for today.
Okay.
All right?
So I should be doing Peterson step-ups.
You should. You need to
Okay.
do some. You can even do some leg extensions,
Yeah.
focusing on an isometric hold at the
Yeah.
top.
Okay. Like with my leg bent.
Yeah. So seated leg extensions. Okay. Let me just wipe this off here for you. You can straighten your leg for me. There we go. All right.
Yeah.
1 second. Let's just retest you. Lie back down on your back for me. Any sensitivity? No. Look at that. No impingement at all. I told you sometimes there's a big sensory component to
Yeah.
an injury.
That's really strange.
That's crazy, right?
Yeah.
We
I didn't
just
even-
did an electrostimulation upstairs
Wow.
and there was still discomfort in the knee.
Yeah.
Then we did shockwave. What we should have done is tested the range of motion after we worked on the joint itself. Regardless, I still think that it's the reduction in the sensory component that can improve your guarding reflex.
Yeah.
Okay?
Yeah.
All right, let's head into the gym.
Okay.
You'll start in this position, okay? I want you to start without a wedge under your heel. So
Flat shoes.
flat shoes,
Yeah,
yeah.
I have some. I have the Vibro, the barefoot.
There we go,
Yeah.
okay? Do you have any wedges that you use for training?
I have a heel lift for my left side, right side.
That goes into your shoe?
Yeah.
Okay, no, that won't work.
I can take it out. Like when I
No.
wear flip-flops, I don't wear it.
So there's going to be an upgrade to this, which
Yeah.
would be to lift the heel.
Oh, yeah.
But when you
yeah.
lift the heel, it increases tension on the knee.
Okay.
Okay, so we want to go in steps just so that you're comfortable.
Yeah.
Okay, so you'd start off in this position, okay, and you're going to step down. You want to go slow. It needs to be an eccentric. Slow, touch, pause, and then squeeze and come up. Squeeze the quad. Down, slow eccentric, pause, squeeze and come up. Let's
Okay.
give that a try. Yes, pause 1 second, squeeze, come up. Keep that quad really tight in this position, okay? Down. Squeeze, come up. Slow eccentric, pause. Slow concentric, don't burst out from the bottom.
Yeah.
Okay. Pause, come up. Push through the foot. Come
So
up.
can I ask you, as I bend, do I stick my bum out further or can I go forward?
Yeah, you can go forward.
Okay.
Yeah. There we go. And up. Yes, nice. Look at that ankle working nicely. and squeeze. Okay, so this is pretty easy, right?
Yeah.
Let's give you a wedge. Now, let's see, this may be two. Let's use one of these weights. Just pop your heel on there.
Mm-hmm.
There we go. Same thing now. Pause. Yep, and up. How's that? Makes it a little bit harder coming out from the bottom.
Yeah.
Yeah.
I feel like I'm just tipping a little.
Yes, that's okay. Use your hand as balance. Down, down, down. Pause. Up. Squeeze. And come up. Okay, so you want to try and do as many reps as possible.
Mm-hmm.
The ATG protocol suggests doing 25 reps.
Okay.
Okay.
I can do that.
So it's pain-free for the moment.
Yeah, it's pain-free.
I don't think there's a reason why you can't do 25 reps.
Yeah.
4 rounds, 25 reps.
Okay.
Okay. This would be a great way for you to start loading. You can also do front leg raised split squats.
Front leg
Raised split squats.
Sorry, just show me that.
Okay, so let's get you in this position here on the bench. Okay, so get your right foot slightly further back for me. Okay, there we go. Right. Okay, now keep your chest up, but I want you to move forward on your knee.
Yeah.
Yes. Oh. Okay. 1 second. Come back for me.
Yeah.
Place your arch of your foot here. Yeah. There we go. Right.
Okay.
Okay. Now chest up. Right. Go forward on the knee. Any sensitivity? Right. Pause in that position. Now push through your arch and come all the way out through the knee. There we go. Again.
Can I lift the back heel?
Yeah, lift the back heel. Pause. Push through the foot. Don't move through your hip. Push through the foot and come out.
Yeah.
Oh, you're moving from your hip. Okay, let me show you what you're doing.
Yeah.
So, you moving here
Yeah.
rather than moving there.
Oh, yeah, I see the difference.
Okay?
Yeah.
So, if you want, you can bring your foot a little bit closer.
Yeah.
Okay? Move at the knee joint,
Yeah.
not here at the hip, and the knee comes second.
Okay. My brain understood that. Let's.
Yeah.
Is my body doing that?
Yes. Go for me. Knee, 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 knee. As deep as you can go. Pause. Don't be loose. Okay? Don't be loose. Keep the tension in the quad. Now push through your foot and come out. Okay. You're struggling with the surface and control. I think you don't have any friction here on the surface. So a shoe would be really
helpful.
Great.
Yes.
So you can create some friction and improve your stability. Okay. Your foot is working really hard to stabilize you. I think once you rectify that, you'll feel more comfortable on your knee because you're not having any knee pain when doing a front leg elevated split squat. Okay. This will take your knee into flexion and load your quad so you can become comfortable with it again.
Yeah.
Okay.
Okay.
Just remember you want the movement to come from the knee joint and not from the hip.
Yeah.
Okay.
Yeah. Got it.
All right, great. So again, with the front leg elevated split squats, you can do up to 25 repetitions.
Yeah.
As long as there's no pain. Okay.
Yeah.
All right, guys. So I think we're going to end this video here. It's been quite a nice treatment session. We've been able to do some intramuscular electrostimulation. We've been able to do some shockwave therapy. We've done some rehab. And all in all, I think your symptoms are much better than when you came in. Yes?
There's so much more mobility too.
There we go. All right. So this is a very interesting case because I would say that a lot of patients, like we discussed earlier, would probably say, oh, you know what, screw it, let me just go do an arthroscopy. Let me fix everything up, that will resolve my pain. But there's a big sensory component to this issue, okay, a neurologic component. And that's what we addressed in the modality room with the shockwave, and that already improves symptoms, okay? So hopefully you'll see Caroline on our YouTube channel again soon. Please follow us for progress on Caroline's case. Do you want to let all our viewers know where they can find you and where they can follow your journey on social media?
Caroline.d.leon on Instagram. Yeah.
All right. Okay, guys, thank you very much for watching. If you like this video, please hit the like button, subscribe, and drop any comments you may have in the comment section below. Take care.